afternoon, everyone. Good afternoon. It's a pleasure to be here again, Dr. Mills, Dr. Dubin, members and guests. Thank you for the opportunity to present on this topic that has remained very relevant and very important over the last several years, ever since the explosion of telehealth during the COVID pandemic and the public health emergency. I have no financial disclosures, but I am the AUA representative to the Alliance for Connected Care through the Telehealth Task Force. So that is a telehealth advocacy organization, and so I do have to acknowledge my positive bias of liking and doing a lot of telehealth. And so we're gonna start a little broadly, billing and reimbursement, give some health policy landscape updates and how this ties into the reality of if you're not doing it already, do I dive in now? Do I wait till January 2025? We'll talk about that. And then just some how-to tips and best practices. 2 years ago when I talked about the research side of things, I hadn't been doing my own telehealth visits, but now I've really had that day-to-day real-world experience. And so I wanted to start off with the things that we all know, but sometimes doesn't necessarily get acknowledged. Money drives things in the world, including institutional decisions. So something that's often quoted or cited is that, well, telehealth visits are going to reimburse at a lower rate. So even if it's the better thing for access, for patients, for convenience, we shouldn't be doing it. And part of that was actually data from the University of Michigan that I was involved in. But this is now outdated. This no longer counts. So since the 2021 billing changes, the medical decision-making that you're doing as a urologist, as a physician, and other providers that work with us in the clinic should be billing at the same level, should be getting charged at the same level, because it's not only based by time or how easy, quote unquote, the visit is. So this is just an incredibly important thing to keep in mind. And this is why. Really, you're using two of these three categories: the number and complexity of problems, complexity of data reviewed and analyzed, and the risk of complications, morbidity, or mortality of patient management. And just as a little hint, tip, or trick that other folks have shared is, if you're prescribing a prescription medication, that's already a level 4. If you have a new problem with an unclear prognosis, that's a level 4. So it's very common, almost by default, most urologic clinic visits where you're addressing either of those two things are gonna be a level 4 encounter. It's only for the rare occasional things where you're providing reassurance, not prescribing anything, not talking about a surgery, that you're gonna fall to that lower level, level 3. Before 2021, one of the issues with telehealth was that you needed, forget if it was 8 or 10, but you needed multiple components of the physical exam to be able to meet higher billing levels. So that's what led to that issue with most of them being level 3 visits. Unfortunately, even with the billing changes, a lot of that has carried forward. We even see that at our own institution, UCLA, where folks say, well, I feel guilty billing more than a level 3, and we really need to be billing and appropriately capturing the work that we're doing and how we're helping our patients. One of the things that's going on now is still the ongoing challenges and the uncertainty about how is everything gonna look. So many of the things that have occurred since the public health emergency have just been temporarily extended. And so phone visits, for example, are now reimbursing at a much lower rate than very early during the process, or they might have no reimbursement depending on the insurance that a patient has. So there might be some health equity concerns here, and this is something that the AUA is looking into and talking about. And I wanted to point this out. We're in October. December 31st, 2024, if Congress doesn't do anything, many of the telehealth flexibilities and extensions that we've had will just vanish, will just disappear, which would be a tragic thing for our patients. So I wanted to put this on everyone's mind. And these are some of the things that have really been impactful and influential, particularly in terms of extending access to care, has been some of the things that were codified with the Consolidated Appropriations Act that allowed for new patient encounters, so not only return visits, but patients being able to do these visits from home. They didn't have to travel to a facility to do telehealth from a facility. And a part of that many people don't know about, but that direct supervision has been extended, so you can be directly supervising an APP or even residents in the hospital and incorporating billing in some aspect. The DEA, multiple times, there's been concerns about testosterone management. Dr. Dubin brought this up at a previous talk during our meeting. Because testosterone is a controlled substance, there have been multiple times now where there were plans by the DEA to prevent the prescription of controlled substance through telehealth, and through advocacy efforts, the AUA included, we've been able to pause this. And I wanted to point out, Medicaid private payer is gonna vary a lot state by state, so it's an incredibly complex system, and you can't be doing this alone. You have to work with your billing offices as well as your local and regional medical associations. And I wanted to, bring this up at this meeting because I just received this email a couple days ago as I was preparing this talk. So the DEA was trying to push really hard to stop the controlled substances from being prescribed through telehealth, and this email just came through. Over 350 physician and provider organizations sent a letter to legislators, and this has once again become extended. So you can still see testosterone replacement through telehealth for the moment. So now let's turn our attention to, how do we do this in your world, in your clinic, in your organization? First of all, you have to focus on workflows. You need to have a physician champion who partners with IT, with the office and the health system admin, and have staff who are going to be part of the process, part of the team, in terms of making sure that from before visit to after visit care gets arranged. And the critical thing is you have to think of telehealth as a substitution for an in-person visit or in-person care. If you try to create a totally, completely separate pathway, you're gonna have a lot of people doing duplicative work, and so try to integrate it as much as possible into the systems that already exist. And early on, you need somebody who's motivated, who likes this stuff, who doesn't mind sitting in an office for 6 hours at a time, even though my butt gets sore. But that's how you can pilot it, demonstrate that it works, and then extend that out to other settings. And these are the things that need to be kept in mind in those initial planning visits is, how are the visits scheduled? How is the follow-up gonna be scheduled? How do patients prepare? Do they have to have an EMR portal already registered and set up? Is their device or their internet sufficient for video visits? And what happens if there are technical issues? If the default is they just call your office, that's gonna overwhelm the office and cause a lot of issues. So at larger health systems, thankfully there's usually a telehealth group of some sort that can help with the troubleshooting. And then I'll bring this up a little bit later, but who updates medications, the preferred pharmacy arranges follow-up. So there can be some downfalls to taking on, because it may be that you as the provider or the physician is incorporating a lot more EMR clicks, and we'll talk about that. So in my opinion, and I know others here, Dr. Burney and other folks who have used a lot of telehealth since the pandemic, having dedicated telehealth time can be extremely helpful. Certainly from the patient side, patients expect videos to run on time. They're saying, look, I'm just jumping onto my phone or platform. If I FaceTime someone and they answer, we're just able to talk. Why is my doctor running 5, 10, 15 minutes behind? So I have found that really having a half day of telehealth visits back to back to back, I tend to run much more on time as opposed to trying to time it between clinic procedures and other things where somebody may get stuck in the parking lot. One unintended benefit is if you pick a day where flexibility may be beneficial for life, your clinical schedule, et cetera, these telehealth time slots can give you an incredible amount of flexibility. So if going to multiple sites, multiple surgery centers, you can go to one of them, and then wherever you are, just jump into an office and do your telehealth visit, and you don't have to be driving back and forth across town. And then set and refine your scheduling matrix. I know a lot of folks who have done work in this space. I haven't figured out the perfect thing yet, but there are some people who like to do all their new visits up front. They know they're gonna take more of that mental tax, and they would like to do that at the beginning of their telehealth clinics and then finish with follow-ups. Other people, and so far what I've done is alternate some of the follow-ups because they tend to be faster. You know the patient already. If you fell behind on a new patient encounter, you may be able to catch up a little bit and get back on schedule. And then this is another tip from Dr. Burney. Use phone visits during the global period. So you have patients coming in from very far. You're not concerned about their post-op healing, et cetera. You can just call them, set them, and that can be added to the schedule. You're not losing any money because it's part of the global period anyway. So it's a very thoughtful way to incorporate telehealth into your practice for the benefit of your patients. And so this is something I wanted to share. Most of you probably have seen this or heard of it, but the Doximity app is an incredible resource. Not only can you have it to call patients from your clinic number, if your EMR-specific telehealth program is failing, I've used this to still have a video visit and to still be able to put in a charge appropriately like a video visit, because phone works completely differently. And then visit messaging is something that some of our staff members at UCLA taught me about 6 months ago. See if your EMR has a functionality similar to this. And I wanted to bring it up here to see exactly what it may look like. And at the top of Epic, which many people have, there's this drop-down button. You can see visit messaging there. And you'll be able to send one of these predetermined messages to your patient. So if you know you are running behind, and this works for both real clinic and telehealth clinic, but if you know you are running behind, you can say, hey, running late, wait a few minutes, and for the video at the bottom, it'll even say wait in the video versus we're gonna send you a link to join when I'm available. And with the last 10 seconds that I have to acknowledge that there are challenges. EMR clicks, documentation, additional messaging to be able to schedule follow-up because they're not able to just go to the checkout desk. And then the billing that I brought up is something that requires broader work across our societies. And so I'm going to leave this up. I don't know if we're heading into the Q&A session, but thank you very much for the opportunity to present.
Thanks, Juan.